So I think most people know what opioids are at this point. We're talking about chemical substances that reduce pain. With that, we're talking about many prescription drugs. Most brands that people know of are OxyContin, Vicodin, Norco, Percocet. We're also talking about prescription drugs that people use to get off of opioids. Now, opioids are a class of drug where you will continually need to use more of the drug to feel any kind of effect. You build tolerance. So when you choose to get off of them, you also need a medication to kind of lower your tolerance to be able to withstand withdrawal, which is usually physical effects that happen when you're trying to wean yourself off of it. Usually, most people describe it as some of the most painful experiences of their life, kind of the worst flu-like symptoms you can think of, sweating, nausea, vomiting, diarrhea, muscle aches, insomnia. It's usually pretty severe. So medications like Suboxone, methadone are used to help people wean themselves off and be able to withstand and not have those withdrawal symptoms. We're also talking about illicit substances like heroin and more commonly fentanyl. Have people heard of fentanyl before? Good. So fentanyl is an anesthetic. It's about 30 to 50 times stronger than heroin. It does come as a prescription. It is prescribed most commonly as like a patch for pretty severe pain management, kind of end-of-life type pain. That's not the fentanyl we're talking about when we're referring to the opioid crisis. We're talking about a synthetic, man-made fentanyl that's being manufactured in labs pretty similarly to meth. So with that, you get an ever-increasing amount of fentanyl-related substances, right? Things that are kind of alterations of that original drug with various amounts of potencies and strengths. In itself, as I mentioned, it's incredibly lethal. If those are about the lethal doses of heroin and fentanyl together. And keep in mind, those jars are probably about this big in real life. It does not take a lot. And now people can build tolerance to it. But what we are also seeing that fentanyl is popping up in other drug supplies, whether on purpose or just by mere contamination by the drugs being in the same vicinity. But we're starting to see positives within meth supplies, K2 or spice or whatever you want to refer to, synthetic cannabinoids. Also, we've had a crack cocaine incident here in Philadelphia. So these are important things to know because I think when people think about Narcan and naloxone, they think about heroin and opioids. But these are really interventions that everyone should know for if you have people in your lives who use any kind of drugs. Now, what is happening during an opioid overdose? What is essentially happening is that opioid, either alone or in combination with other drugs, is going to suppress the person's ability to breathe. So the breathing is going to slow down and it's going to stop. Now, how quickly that happens is going to depend on what the person used, how they used it, and how much they used. Now, someone who takes an oral Percocet, or maybe a couple of them, their breathing is going to slow down differently than someone who injects fentanyl. Fentanyl, like I said, it's an anesthetic, so it's meant to kind of knock you out, right? If you inject it, it's going to take effect within about 30 to 60 seconds. So time is really of the essence more and more these days. You really need to have Narcan on hand at that time. Waiting for EMS can be too late. So, like I said, breathing is going to slow down, it's going to stop. When that happens, oxygen isn't getting into your brain, right? Your brain stops working and isn't able to communicate to your heart to continue beating. You know, the heart will most likely stop, that person will go into cardiac arrest, and most likely die without intervention. But we have naloxone, or more commonly known as Narcan, the brand. This is our temporary antidote for opioid overdose. The key word there is temporary. It really only lasts for about 30 to 90 minutes or so, depending on the person's metabolism. Now, what is essentially happening when naloxone is administered is that if the opioid is sitting on that receptor within the brain, the naloxone basically comes in and bumps it off and takes its place. If there is no opioid in the person's system, nothing happens. Nothing happens. You cannot cause any additional harm by giving someone naloxone. If you don't know what the person used, if you're not even sure what medical emergency they might be having, we still encourage you, if they are experiencing symptoms of an opioid overdose, that you give it to them. You're doing exactly what emergency personnel would also do in that situation. You have to try a couple things and test it out. So as I mentioned, it will block that interaction for about 30 to 90 minutes. It is possible and common that when the naloxone wears off, that person can go back into that original overdose without additional intervention. Those drugs are still in that person's system. They are still at risk. I'm going to go over some brief statistics just to give you kind of a current picture of where we're at. These are maps nationally for going back to 1999 through 2015, so obviously a little bit dated at this point, but this shows you how this crisis kind of grew across our nation throughout the 2000s. Red obviously being more number of fatal overdoses. There is not currently an area of our country that is not affected by this crisis. I've been to a lot of conferences recently, and there is a panic about what to do about rural America because they do not have the same access to services as we do. They have to drive miles to get to treatments, or there is definitely a big concern everywhere. Here in Philadelphia, we have the highest overdose rate of any large city in the country. Obviously, New York has higher numbers, but they have a lot more people than we do. Our rate is about double the second greatest of Chicago, and we are kind of leading the pack in that way. For 2016, we lost about 907 people in Philadelphia to drug overdose. This past year, for 2017, we finished out at 1,217 people, making this the worst public health crisis we've seen in our city in about a century, surpassing the number of people we lost during the AIDS epidemic, it's about 4 times our homicide rate here in Philadelphia. We say we lose about 3 to 4 people every single day. For this year, we are estimating that we're probably going to finish out about the same. I know that doesn't seem like a good thing, but we're talking about a city that has seen a 30% increase about every year for the last several years. So we are hopefully starting to see a plateau. We're not going to start celebrating yet, obviously, but we're hoping that some of the things that we are doing are starting to work. Of those deaths, obviously the majority of those are opioid related. Not all of them, obviously, but the majority are. The majority of those that are opioid related are due to fentanyl. I think it's about over 80% are due to fentanyl of those that are opioid related. Now, unfortunately for us in my department, fatal overdoses are kind of just the tip of the iceberg. There are tons of other metrics related to this crisis that are having huge impacts on our communities. Non-fatal overdoses are also continuing to increase every year, every day. On the left, we have the number of naloxone administrations by first responders, EMS, police, SEPTA police. Those have obviously gone up every year. On the right, we have the rate of drug-related emergency department visits, which again have continued to increase every year. And unfortunately for us, and one thing we are trying to tackle and grapple with, is that this really only gets to a percentage of the people who actually have non-fatal overdoses in the community, because not everyone calls 911 and not everyone goes to the hospital. So in terms of trying to track some of this, we find it incredibly difficult to try to get actual accurate numbers. On the left, we have the overdose locations for 2017. Those are where every one of those people died. I think this map is extremely important to show because I think when we talk about the crisis in the city, we talk about Kensington. That is absolutely fair. You can definitely see a cluster within the Kensington area on that map, but you also see dots in every single zip code of this city, every single one. I think it's easy to depict Kensington a certain way. Obviously, they're a community that has been incredibly impacted by this crisis. They have had an open-air drug market for several decades, at least. This is something where you are going to see those kind of effects, but we have to be concerned about people all across the city, our neighbors, our friends, our family members. this is happening everywhere. We can't continue to turn a blind eye and say that drug use isn't happening in our communities. It is. It absolutely is. On the right, those are the demographics of folks who died by race and ethnicity. I also think this is important to show. I think obviously this shows that this kind of does depict what the media presents this as kind of a white crisis. I think that might be fair, but I think you can also see by that pie chart that a lot of people of color are still dying, and those numbers are continuing to increase every single year. Those are ratios that are starting to even out for the worse, and that's not something we like to see. I think we need to acknowledge that all people use drugs of all kinds, and that, we need to be addressing those communities as well. And just because society as a whole was late, right? We were all late to this idea that addiction was a public health crisis because a certain group of people were dying, right? And now that a lot of white people, right, a lot of privileged people are starting to lose folks, there has been like this national call to action that should have happened a long time ago. Yeah, just to be honest, yeah. So we need to continue to push these policies that are going to be good for everybody, right? No one knows, this better than the communities that have already been impacted, right? We need to be talking with those communities, making sure we're repairing those communities in our efforts to move forward with some of these policies, right? Medical marijuana, recreational marijuana, can't do that without amending people's charges, right? Giving people reparations for that, right? We need to be moving forward in those ways. So the nitty-gritty of how do you spot something, what you can do. So we're going to talk about risks first, because there are some folks who can be more at risk to have a fatal overdose than others, or have certain situations where they might be more at risk. One big one is obviously mixing drugs. So using obviously multiple opioids together of multiple high strengths is obviously bad. Or not bad, but not encouraged. Mixing opioids with sedatives, like anti-anxiety medications like benzodiazepines, Xanax, Klonopin, alcohol, things that are gonna further depress your breathing are gonna put you at a lot greater risk. Mixing drugs with stimulants, cocaine, crack, more commonly meth here in Philadelphia. I think there's a common misconception among a lot of people who use drugs that stimulant's going to keep you up despite the depressant. That's not really how that works, unfortunately. And then also, just regular stimulant use is going to cause a lot of wear and tear on your body in general. Variation in strength and content of street drugs. I cannot emphasize this enough, that people do not know what they are buying. Drugs are being cut with all different kinds of things these days. We are seeing a lot of synthetic cannabinoids within the heroin supply here in Philadelphia. As I've mentioned, the majority of our drug supply here is made of some sort of fentanyl. So these are things to consider. Switching mode of administration, a lot of people especially have this sort of trajectory when they start using heroin, that they at first usually snort it before they inject. It's a lot less scarier to snort something than to actually use a needle, right? So obviously switching to the needle is going to put you at more risk. Tolerance changes. Any amount of interrupted use, not using for as little as 24 to 48 hours, is enough for someone's tolerance to drop, to put them at risk for overdose. This means a night in jail, the hospital, someone who gets into recovery, maybe someone who gets on medication-assisted treatment for a couple days. That person is at risk. They do have pretty significant tolerance changes. The more time you have, the more at risk you are. This is something we're not talking about within our recovery communities. I say that as a person in recovery. We are not talking about overdose prevention within recovery communities. We need to be giving people Narcan. We need to be talking about relapse plans, right? Because people mess up, people have struggles, right? We need to be addressing those in a way where people are not dying. That return to use does not mean death. And we need to be talking about that. Using alone, people are most commonly using by themselves. People do not want to tell the people in their lives that they are using drugs. That makes sense. They typically want to ship them to treatment, which is fair, right? You want the people in your life to be well, but you cannot force those things upon other people. So people typically use alone in bathrooms, behind locked doors. If no one can find you, there is nothing that can be done, right? And these are hard conversations to have with people in your life. I know from experience, trying to encourage the person in my life to let me know when they were going to use, so I didn't come home and find them dead. Those are hard conversations to have, and they're going to sound it's going to sound very counterintuitive to that person, but it's important messaging to keep putting through because their life matters, and you just need to reinforce that continually. Physical health, changes in liver functioning, weight loss, immune system problems, dehydration, any kind of breathing condition like COPD or asthma. Physical health definitely does play a big role, and if you're already not doing well physically, it's going to make it harder for you to survive that kind of interaction. So, how do you know when to do something? This can be really hard, especially in a city like Philadelphia. I'm not going to stand up here and lie to you. It can be hard to know when to intervene in any kind of given situation. And what I usually say is from this point forward, what you do in any given situation is really dependent on your comfort zone and what you feel like you're able to do in that situation. It's not my job to stand up here and tell you what to do. And I will also stand up here and tell you that every overdose that I've responded to has looked different. Every single one, and they are going to look different. And you can play that game in your head, okay, of what if this happens, what if this happens, but you just also have to be comfortable that some of this, and you're going to know how to respond. And you're not always going to do it perfectly, and that's okay. You're going to make some mistakes. This is a little complicated. I know it's supposed to seem easy because it's a nasal spray, but it's not going to always be, and that's all right. If you see someone who's really high, and this happens a lot in Philadelphia, right, guys? We see people a lot who are really high. There's a lot of public drug use in Philadelphia. So if you see that person, the biggest advice I can give is to just check on them. Just make sure they're okay. Hey, man, you doing all right? You need any assistance? This person is most likely going to respond and tell you to move along your way because no one is trying to get Narcan today. Nobody. It induces withdrawal. No one is trying to get Narcan. So that person who's really high, right, they're most likely going to be going kind of in and out of consciousness, right, but still responsive, still breathing. And that's not to say that person isn't at risk for overdose. They could go sit down somewhere and have their breathing slow down and stop. They could be at risk, but you cannot monitor every high person on the street. It's just not realistic. I usually try to recommend if there is someone who's kind of in the area, like a security guard or a septic cop, or maybe someone who's just kind of standing around on the corner because people do that. Like if someone could just check on them and make sure they're cool, that's, again, the greatest advice I can give. Just check on people. Just make sure they're okay and breathing. When you know you need to do something is when that person is not breathing, right? And if they are not breathing, they're going to start to get pale, gray, depending on their complexion, blue in the nail beds and the lips, that is going to spread. They will most likely have some sort of heartbeat. It'll be pretty irregular. With the fentanyl, we are seeing a ton of body stiffness. Their muscles and their entire body will kind of lock up like this. Jaw will lock. Sometimes you see some kind of seizure-like movements or severe like muscle spasms and tremors. It can look very different. Other people can just kind of just fall down and fall unconscious, right? So it can look different, and you just kind of have to be prepared for that. But like I said, some of these are kind of like a big warning sign. If you see someone who is on the ground, unconscious, you're really not sure if they're breathing or not, the biggest thing like I said, you can do is to check on them, try to wake them up. I say this with a caveat, right? We have a fair amount of street homelessness here in Philadelphia. You do not want to wake up every single sleeping person on the street, right? You got to use your best judgment. Does it look like that's kind of their bed area for the night, right? Does it look like they kind of tuck themselves in and like they're cool? I still try to check for breathing, right? Still try to see if I see their chest moving or maybe some air if it's cold out, right? But try to use my best judgment. But again, do not wake up every sleeping person in Philadelphia. They will not be happy about it, I can guarantee you. But to try to wake them up, we do recommend, if you see someone who's in like a really awkward position, right? They're really not looking good. Yeah, you might want to see if they're okay. So, you would do this just like any other emergency situation or someone who looks like they're in distress, right? Hey, you okay? Do you need any assistance? I'm going to step away. So hopefully my voice is still going to travel. Can people hear me? No? Do we have another mic? No? Okay, hold on. Let's see if we can. There we go. There we go. So you're going to be, hey, are you okay? Do you need anything? You're going to want to maybe tap them, maybe increase that, make that a little harder. If not, we really recommend you apply some kind of painful stimuli. The first thing I usually recommend is what I call a nail bed press. It's not a technical term or anything, but you're going to press on the inner part of the cuticle. It's going to hurt, hopefully wake them up. If they do wake up, they'll most likely pull away and not swat you in the face. It's just a tactic. If next they don't wake up, we recommend sternum rub, thumb between the other fingers, rubbing on the breastbone. Again, it's going to hurt. Hopefully wake them up. If not, we do recommend one final thing, and it's going to seem silly, and based on the other things I just told you to tell you, they should have woken up to. This isn't going to make sense, but it does work. You're going to say as loudly as you can in their face that you're about to give them Narcan. I know it shouldn't work. I know it shouldn't. But it does happen, I would say, at least 25% of the time. They pop right up. If none of those things work, you want to kind of get into action. Now, what you do first, whether it's calling 911, giving the Narcan, is going to depend on who's there, who's with you. If there's multiple of you, one person should be calling 911, the other person should be getting the Narcan. If it's just you, I usually recommend starting the 911 call, putting it on speaker, so you can be talking to them and not holding up the process of giving it to them. Like I said, time is of the essence. You don't really want to wait. When you're on the phone with 911, you want to give them their exact location. They're pretty particular about that, so I want to tell them exactly where you are, describe the symptoms. We have a standing order here in Pennsylvania. That means several things, and one thing it means is that you do have immunity to report and intervene in an overdose. You are covered under the Good Samaritan Act. You are acting for a person who is unconscious, unresponsive, and cannot care for themselves. So you cannot be sued if something goes wrong, if they do not survive. You cannot be charged with drugs or drug possession or anything like that if the cops show up. So everyone should feel comfortable calling 911. Next, you want to give the naloxone. I'm going to go through the different versions in a second. They are a little different depending on which version you have, but we'll focus on the one nasal spray that y'all are getting today. That's very exciting. I'm so happy to hear that you guys are going to walk with it today. That's kind of the biggest barrier, is getting it. When you give it, you just want to be sure of the time. This is kind of a delicate process. Intranasal naloxone takes about 5 to 8 minutes to kick in. But 8 minutes without oxygen, you're probably what? Yes, exactly. So you do not want to wait that 8 minutes completely. We usually recommend setting a timer on your phone, or at least just double checking. I will sit here and tell you honestly, I have never remembered to do this, but that 911 call that you made, that's a really good way to keep track of it. You want to wait I usually say about 3 to 5 minutes, erring on the side of 5, before you give that second dose. Like I said, Narcan induces withdrawal. The more Narcan you give somebody, the worse their withdrawal symptoms are going to be when they wake up. And I know it sounds counterintuitive that you would worry about such a thing when you're trying to save their life, but if they wake up completely sick, they are most likely going to run away as fast as they can to be able to amend those physical feelings that they're feeling right now, the best way they know how, the way they've learned to know how, right? So you actually want to try to only give them one dose and see if it works, to try to ensure that you try to minimize some of those effects that they're going to feel. This is obviously the Narcan. It's the brand, really easy to use. Can't mess this up. Really can't mess this up. 2 fingers, thumb, press. That's it. That's 1 dose. 2 doses come in a box. This part will completely fall out. You throw it out. It's done. If I'm going to do it to Jerry here, just up the nostril, thumb, press. That's it. Like I said, can't mess it up. Super easy to use. Like I also mentioned, it can be pretty expensive and hard to access. It is covered through all the Medicaid plans when you get it through the pharmacy, so they get it at a 0 copay, which is cool. If you are like the many people in this country who have a commercial plan, that copay is going to vary pretty greatly. I've heard as little as 25. Mine used to be about 40, and I had one poor Drexel intern who had their insurance, and hers was about 120, which means they were covering about like maybe $10 or $15 of the medication, which is super cool. And it's pretty expensive anyway. We at the city, we buy it at a discount. It's still $75 a kit. When I started this position, our program was new. Our program's budget was Narcan and our salaries, because it is important to have a lot of it. People inject several times a day here in Philadelphia. I think the average is about 6 to 10. You need a lot of Narcan to be able to have an impact. So it does add up. I should have mentioned expiration. They do expire. The expiration is usually about a year and a half to 2 years out. However, Narcan has been shown to be effective up to 6 years after the expiration date. Do not throw those doses out if they expire. If you do not feel comfortable using them, feel free to give them to me, Prevention Point, anybody will happily give you a replacement dose. Do not throw them out. Because of the high cost, I still teach people how to use the generic version. It's obviously the inferior product, right? You got to put it together. It's not as concentrated. However, it did used to be free with my insurance, so that kind of won it over for me a little bit. I learned how to use it. So I just always tell people to remember to take off the colored pieces. You're going to take off the yellow, pop that purple cap off, twist it in until you feel it kind of stop. Take off the other purple cap. Now, EMS actually uses this version. If they get on the scene and the person has been down for a while, they can put a syringe on top and go intramuscularly or intravenously if they have to. With us, you're going to the pharmacy will most likely waive the fee for this atomizer. You just twist that on top. That turns the liquid into a spray. So with this version, because it's not spring-loaded like the other version, you do want to make sure that you actually get it in their system. So you're going to actually push their head back, about half in one nostril, half in the other. Just about. It doesn't need to be exact, but you just do want to make sure that it's all getting in there. And like I said, it just is much more cost-effective. And a lot of people who work pretty closely with people who use drugs and people who use drugs tend to prefer this version. You can titrate the dose a little bit better. You're not just hitting them with 4 milligrams. It's just kind of a softer wake-up sometimes. So this is historically how they used to teach people how to give naloxone. They definitely still do this in some places, more commonly like in Canada. But they give out 10 milliliter vials and teach people how to draw it up with a syringe and give it intramuscularly in the arm, thigh, or the buttocks. I don't teach people how to do this because I can't get people on board with a nasal spray. But if you'd really like to learn, I'm sure I could find someone to teach you. In response to that, the makers of the EpiPen came out with this product, the FZO, and it is super cool. It is an auto-injector that's going to talk you through the entire process. So not only are you getting the faster administration, you don't even really need to know how to use it. Pretty cool, right? But like all good things in life, this is super expensive and inaccessible. It came out at a couple $100. It is now valued at over $4,000. And because your insurance is going to cover the nasal version, you have to go through a prior auth to get this one, which isn't always easy, right? I hear they give a lot of donations to nonprofits, so any nonprofits out there, definitely hit them up. I don't understand why they don't just lower the cost, but it's whatever. But I'll show you how to use it anyway in case you come across it.
This trainer contains no needle or drug. If you are ready to use, pull off red safety to inject. Place black end against outer thigh. Then press firmly
and you would just put it right like this in the leg, and you just hold it.
2, 1. Injection complete.
And that's it. Like I said, super easy, super cool. Not the most accessible thing, but that's medical health in our country, right? Big Pharma owns everything. That's super cool. Capitalism kills. So, with that, we're going to talk about what else you need to do in this emergency situation. So, like I said, you're going to call 911, give the Narcan. You're going to want to wait that 3 to 5 minutes. Now, in that 3 to 5 minutes, and this is where I usually lose people, so stay with me. We really encourage you to be doing rescue breathing, not full CPR, rescue breathing. People are dying from lack of oxygen. It is encouraged that you try to circulate whatever oxygen is left in their system. If you are maybe at a healthcare facility and have like an ambu bag you can use, even better. But if you are on the street where a lot of these incidents happen, probably will not have something like that. We encourage you to get creative. I myself have used my shirt before. I also carry around this handy dandy CPR kit that I got off Amazon for a couple dollars. It has gloves and one of these disposable face shields you can get. Can't really mess this up, right? Just put it on their face, breathe through it. I also encourage you could cut the bottom off of a cup, cut your hands together. Again, whatever you feel comfortable doing, get creative. It is truly important. It has been shown to buy people time even when they didn't have naloxone on hand. It is extremely, extremely important. Now, like I mentioned, you don't want to do compressions also unless they are actually in cardiac arrest and their heart has stopped. The biggest thing to consider before you do this is you want to make sure the airway is clear. You want to check. It is very common for people who inject drugs to get kind of a metallic taste in their mouth when it hits their bloodstream. So sometimes they eat like candy or lozenges at the same time. So you just want to make sure it's clear. If it's not, if you have gloves, 2 fingers, fish it out or roll them onto their side and pat it out. And then if you're going to do the rescue breathing, we just recommend you do 1 breath every 5 seconds. I'm just going to push his head back, pinch the nose, and like I said, 1 breath every 5 seconds. I'm going to use my shirt. And then you would do a full 1 Mississippi, 2 Mississippi, 3 Mississippi, 4 Mississippi, 5 Mississippi, most likely in your head or if you need to out loud. It's important to do the full Mississippi to make sure you're not going too quickly. You don't know how long you're going to need to be doing it. We encourage you to do it until they start breathing again or until EMS arrives. And if there's no one on scene or no one else who's willing to do this, you might be doing it a little while. You might get tired. So again, 1 breath every 5 seconds. Now, it is very common for people who are given naloxone to start breathing before they're fully conscious again. Sometimes it takes them a little while to actually get up and moving again. We encourage you to put them in the recovery position on their side. It's pretty common for people to throw up after being given naloxone. You want to ensure if they are breathing but just not conscious that if they do throw up, they don't choke on it. We also more commonly, with the synthetic cannabinoid contaminations, have seen people have seizures after being given naloxone. So in that case, again, you want to keep them on their side, try to hold their head, try to keep them from causing any further harm to themselves. Now, after overdose. Now, this part still is not that simple. It's really going to depend on the circumstance. If they don't become conscious again, if EMS just comes and takes them, your part's pretty much over, right? You can go about your day. If they do wake up, we really do encourage you to try to have the most kind, compassionate, respectful conversation you can with that person, knowing that they might not necessarily be happy with you in that moment. That has to be okay. You have to remember the physical symptoms that they are starting to feel and what they immediately want to go do right now, what they have been conditioned to go do right now, right? You want to try to explain to them the best way you can, especially because most people who are given naloxone don't realize what happens when they wake up. Sometimes we have people literally pop up and be like, oh, I don't use drugs. It's pretty clear to everyone else that you might. So you just want to, like I said, as respectfully, kindly, as compassionately as you can, explain to them what happened. Tell them that they overdosed, that you gave them naloxone. Make sure they understand what naloxone is, right? That those drugs are still in their system, that they're still at risk for overdose. You obviously want to try to encourage them to go with emergency personnel. But, I'm not a person who seems like I use drugs, and I don't like going to the hospital very much, For people who do appear to be people who use drugs, it can be an incredibly stigmatizing experience for people to go to the hospital. They can be left in hospital bed with those withdrawal symptoms not managed, usually are not treated with a lot of respect, right? There's a lot of reasons why people might not want to go. The most important thing after an overdose is that they're monitored by anyone, whether it's at another drop-in site or maybe they have a friend's house where they can go to. If there's someone who's street homeless, maybe they have, kind of a community that they can let know so they can watch them, right? Just anybody, making sure that once it wears off that they just don't go back into that overdose. You really want to try to encourage them not to use again. Again, that's going to sound counterintuitive. The best way I can explain it to someone who's using drugs is, because the naloxone is in your system, you could go buy more drugs. That's going to be a waste of money, and you're not going to feel it. And it's most likely going to put you further at risk of dying. I think that's pretty right where that person, it's going to be a waste, so just try to explain that the best way you can. Obviously, 4 to 6 hours would be cool. At least 1 to 2 is even fine. Prevention Point. Have people heard of Prevention Point here in Philadelphia? Yeah, cool, great, yeah, love them. So Prevention Point is our harm reduction organization here in Philadelphia. They are historically a syringe exchange that opened in the 90s, but to just call them a syringe exchange these days is, I think, an insult. They do so much more than that. They offer so much medical treatment. They're actually the only syringe exchange in the country that has an HIV clinic attached to it, so they do regular HIV testing and treatment, hepatitis. They do have a drop-in center that's open every day of the week where people can get meals and get connected to services. They are some of the only emergency housing in Kensington right now. You name it, they do it. If you know people in active addiction of a drug of any kind, there is no better, safer place for them. I can guarantee you that. Standing order. We have a standing order here in Pennsylvania, like I mentioned, and other than immunity, it also allows you the opportunity to walk into a pharmacy without a physical prescription and request naloxone and have it billed to your insurance and get it. This is supposed to be an easy process. It's not necessarily. We are trying to address issues with stock and pharmacists' knowledge of the standing order. There is a lot of education that needs to happen for people, and I promise you we are working on it. We actually just had a bill pass in council that will require pharmacies to stock naloxone, and we are pretty excited about it because there's really no reason why a pharmacist shouldn't, and it's something they should always have. And as I mentioned, you can, the standing order also, gives you that immunity. You cannot be held liable for responding or reporting the overdose. You cannot be charged with drugs or drugs paraphernalia if the police come. As I mentioned, there's a lot of different pharmacies right now where you can get it. The stock has gotten a lot better across the city. Hopefully this bill will kind of nick the rest of those other pharmacies in the bud. If you don't feel comfortable going to your pharmacy, if your copay is too high, if you don't feel comfortable billing your insurance, which I have heard from a lot of other people, that's fair. I'm not, like I said, I'm not here to tell you what to do. If you have interest in getting more Narcan, another place you can get it is Prevention Point. They do offer kits. They do sell them for $40, but if you don't have an ability to pay, I'm sure they'll work with you on it. As I mentioned, it is just an incredibly expensive medication. We are just really trying to create structural systems for this drug that we so severely need and will continue to need beyond this crisis. So if you are having issues getting it, again, also just feel free to contact me. Here is my information. That it's also on some cards that are in the back. If you need any technical assistance, if you know groups that want this training, I go and do this for a lot of different kinds of people, a lot of different kinds of groups. Please feel free to reach out. Like I said, we are trying to do a lot without a lot, and we just really encourage you to reach out if you need help, because we're here for that. And with that, should I take questions or no? Yes, no? Okay, never mind then. So that's my time, and thank you guys so much. You were great. Have a good one.
So we do need to wrap up. Before people leave, I want to ask your indulgence for 1 second. If everyone could raise your Narcan kit in the air. We have hundreds of you out there who are now equipped with this life-saving drug, and we would like to get a photograph of it. While that photograph is being taken, I'm just going to remind you that there are more resources in the back. Please take some doTERRA bags before you leave. Allison is also going to be back there for a little while, so if you have questions, please grab her and ask her your questions. And I also want to remind you that we do have resource cards that will be distributed in the next few weeks. Please take them for your clients, for yourself. Stick one in this Narcan box that you have. So if you do end up having to use it, you'll have a card right there and can call the resources available to you through PHMC, through the city, and through the state. You want to back up? Good. Good. Thank you all so much for being here today.